delighted now to introduce Vincent Lubrano. Vincent Lubrano is a neurosurgeon from Toulouse, and we were talking about sparse data before. Well, in the area of neuroscience and brain surgery, sparse data is what you have to live with. And in fact, I think I'm right in saying that the brain has been hidden from view for so much longer than almost any other body system. I mean, the first regular use of CT scans and MRI, which revolutionized the knowledge of the brain, they were less than 40 years ago, regular use. So it's been an extraordinary development. So Vincent, tell us more.
Yeah, thank you, Vivian, for this nice introduction. Oh, sorry, I have to go back. I don't know. Well, doesn't matter. So thank you for this introduction. Thank you for the organizer to invite me and giving me the opportunity to give my opinion and express my view on how I see data and computational science in surgery. So as a neurosurgeon, I usually deal my daily practice with patients harboring brain tumors. So I will illustrate my talk with such a case. It's a 39-year-old male, and he works as an architect. He's right-handed. He experienced seizure a month before I saw him at the consultation. An MRI scan was performed, showing here, you could, well, previous slide. Yes, thank you. Yeah. You can see here a brain tumor in the temporal lobe that is quite more large than this in other sequences. So the patient had to be operated on, so we performed a big comprehensive assessment that included imaging, included behavioral testing, electrophysiology, and biology. And this allowed us to rebuild its brain in 3D. We, what we call, segmented the tumor. That means that we draw it, you can see it in red. Oops, so I do not master this tool. Here, the tumor in red, and here you can see in purple, green, and white the different tracts that connects the different brain language areas at the surface of the brain, and that goes inner in to surround the tumor and making its excision more difficult. So the patient also had what we call non-invasive brain mapping. That means that we created, through magnetic stimulation, virtual lesions of his brain that are totally reversible, just to understand what areas are essential to do a task. That means when we stimulate the brain, the patient is doing a task, for example, is naming an object, and if the area that we stimulate is essential to the accomplishment of the task will be stopped. And we know from that the area is essential to accomplish the task. Then the patient was operated on using an awake-asleep awake technique. The patient was awakened to reproduce the task so that we could test intraoperatively his language while performing the surgery. Can you please launch the video? You can see it's a microscope view with, on the right side, the cranial, on the left side, the caudal, on the upper side, the ventral part, so that's the temporal lobe. And we can see with a small instrument, we deliver a little current so that we will inhibit the brain. And if, when the patient accomplishes the task, is inhibited, the task is stopped, it means that the area that is tested is essential to the task. And what you can see here, the lines that are under the surface of the brain, they represent the tracts in 3D with different depths, okay? That's the reason why it's not continuous line, but only small lines. And we perform it all around the surgery so that we can excise completely the tumor or do a subtotal resection stopping at functional boundaries. You can see here that we use what we call neo-navigation. That's a kind of a GPS system with all the images that have been acquired preoperatively. We use it to localize the different area of the brain intraoperatively, okay? So here you can see the huge amount of data that is necessary to perform such a procedure. And everybody understands that as for the methodology, in order to rebuild, to draw the tumor in 3D, you can see here that we've been using learning machine to do segmentation of the tumor, because the tumor is the brain is not homogeneous. There are several parts. There's a bulky part that includes the enhancing and non-enhancing and the necrosis, and that's what we call the edema. That's the non-bulky part of the tumor, and that through this edema that spread invasion. And this has been done through machine learning, you know, because when you want to do a reconstruction of the brain in 3D, you need to draw the tumor by yourself in around 200 slices. So it's quite a long process, and that's the reason why we use some algorithm to help us to do so. Doing so, we also can perform some studies to make correlation between the characteristics we have in the imaging with biology, performing some biopsies in very target area and make correlation between MRI characteristics of the pixel and the biology of the brain at this place. And then we can differentiate some more aggressive area of the tumor, some less aggressive area of the tumor that could also then in the future predict us how the tumor will grow from different place and won't have a linear rate progression. And that will be partly explained to you by Stéphane Urquin, who has worked on the modeling of the brain. But we also use some different system of computer science just to see the tracts in the brain. We have some collaboration with the National Civil Aviation University in Toulouse, just to reconstruct the different tracts of the brain in 3D and trying to put it in at least virtual reality and then augmented reality to match together the different tracts in the brain with the patient itself to have better visualization just before opening the patient. All these data that you've seen, the stimulation data, can be co-adjusted together. We can have some collaborative studies, and there have been some predictive maps of localization of function, some prognostic maps of deficit that could be acquired after surgery if we touch such areas. And we can also perform so with also different types of electrophysiology, not only direct stimulation of the brain, but also recording of the brain through EEG or other techniques. Oops, sorry, I do not really master this. Okay, so not surprisingly, emerged in the literature recently the concept of surgical data science, and it deals with the capture, the organization, the analysis, and the modeling of all these procedural data. And you can see here that the origin of that is the multiple data source that we can have that are processed through different methods and techniques. Nowadays, the most employed technique is machine learning, because it's the one that is the most easily accessible to the kind of data we have, either imaging or clinical data. But there are also different types of data that can be used. And all of this will probably help us to better define the lesion, better define some prognosis scores, and also better define support in surgery and better define decision and support making. So the message is that surgery is probably moving from something hearty to something more scientific, and all the data that we'll be gathering and analyzing will promote and help us to do so. And the next generation of scientists here will probably be involved in this modification of the healthcare. And what is important is to bring together the engineering and the clinical expertise, so that on the way the methodology are mastered, and on the other way the data are understand and better contextualized. So thank you.
Thank you so much. That was absolutely fascinating. I mean, I think one of the things that is happening is that we used to think of the brain, or indeed any other part of the body, as a bit like being a map. And Luxembourg was always in the same place on the map. But as a neurosurgeon, you know that every patient whose brain you look at is different. Yeah, and they are unique. And so we've gone from a one-size-fits-all approach in medicine to a much, much more personalized approach. And brain surgery is the ultimate in personalization, because all these little circuits can be in different places in different people.
Yes, that's completely true. There's, of course, a general model, and from that general model and from each personal history, culture, capacity, and that's typical, for instance, in the bilingual people, they organize their brain a bit differently. And the people, there's also different models, because on one part there are the people who are what we call healthy people, and on the other way there are the patients who are suffering a pathology. And the pathology induces modification in the organization of the brain. So the patients we have to deal with are already at the very beginning different from the healthy ones. And we had to derive our models from the healthy ones to really the pathology. And there's also the importance of timing, because the brain we organize differently when the timing is sudden, such when you make a stroke, is totally different than when you have a tumor that grows slowly. When the tumor grows slowly, it makes let the brain have the capacity to reorganize itself to get a better functioning as better as it can.
Now, at the moment, the use of data is not really taken up by many surgeons at the moment. And you, what I'm getting from you, is that it's not only a new specialty, but it's one that is really going to grow very fast.
It's going to grow because the technology that is most commonly used nowadays, as you said, is the CT and the MR. The MR and the CT, the structural MR and the CT, it's been here since the early 80s for the CT and the early 90s for the MR. And there's been a lot of progress in different sequences, but the difficulty is to put the academic knowledge into the clinical practice in all centers, because there, in France and in all countries, there's also a question of cost, a question of reimbursement, because doing large MRI sequences with information on the metabolism of the brain, on the perfusion of the brain, on the diffusion of the brain, it took a lot of time. So it's not available in each places.
So there's a challenge there for all of you in that in the algorithms needed to make it cheaper, and the biggest issue in healthcare is workforce. There are not enough Vincents. There's a huge deficit in the number of healthcare professionals that there are to read scans, to do multiple analysis. So this is where AI...
It's really coming in the diagnosis field, yeah. But it's a bit, it's getting a bit later in the therapy.
So there are huge advantages. Stefano Cry, you here? Hello. Because this is your field, so tell us a bit about your thoughts on this, your reflections.
Yes, thank you. Thank you, Vincent, for this very impressive process you presented. I have one question for you. Have you experienced this very well-tailored process. Have you ever experienced to transport them to other clinics, and how very well-trained algorithm to specific data set of these clinics, how can we adapt it to other clinical center?
So is your algorithm portable?
Yeah, no, we had this idea at the very beginning because it's a challenge to have clean data to feed algorithms. For instance, when you acquire some images, there's coming from different manufacturers. You have Siemens, you have Philips, you have GE, and they do not have all the characteristics. And also all the radiologists, they do not have the same protocol from the same pathology. And on top of that, there's also, as in the industry, a question of format, because the medical format is different from the one of the scientists use. The doctors use a DICOM. The scientists mostly use the NIFTY format. The change of format is not a big deal, but the difficulty is that in that field, almost each center developed its own techniques. Each center has its own algorithm feed with his own patient data set, and now we are just at the very beginning to have more exchange between us. But the difficulty is also on the property of the data, the security of the data, the ethics of doing different studies from different patients.
And a famous thing in medicine is not invented here. So if you have something that works in one center, they're very unhappy to use it in their center because it was that terrible Vincent who invented it. So therefore, I need to invent my own. And that is a big, big issue. I mean, I'm joking about it, but actually it is a major problem in rapid adoption and diffusion of technology in medicine is, can you make it work within the systems that are already set up? And it goes back to your point, James, about people wanting no change. So they want everything changed, but they want no change. And that's an issue. And maybe Luxembourg is particularly well placed to think about algorithms that are common, languages that are common, that can be applied widely, that can stop all this kind of flag planting and, you know, I'm going to use a terrible British expression, which is kind of willy waving, we call it, where people want to be, you know, they want to show that they're the best, but actually they're impeding progress because they all want to develop their own systems. So there are lots of things that science needs to address. There are things that industry wants addressed, problems that they face that they don't have the answers to, but they want them. And there are the known unknowns, but also there are the unknown unknowns. And I think that AI is going to uncover a lot of those.